Upper GI hemorrhage is above what landmark? Above ligament of traits. Origin insertion of ligament of traits. Origin, right crus diaphragm. Insertion, celiac trunk, anchor duodenojejunal flexure to retroperitoneum. Non-variceal causes of upper GI hemorrhage. Peptic ulcer, gastritis, Mallory-Weiss tear, GAVE, portal gastropathy, Dieulifloy lesion, Menetrier disease, tumors gist. Variceal causes of upper GI hemorrhage. Variceal means swollen enlarged veins. Portal hypertension. Most common cause of upper GI hemorrhage. Peptic ulcer, duodenal greater than gastric. Types of gastritis. Type A, Type B, stress-induced, erosive gastritis, AIDS-induced. Which gastritis is autoimmune? Type A, autoantibodies against parietal cells, achlorhydria, B12 deficiency. Type B gastritis. Bacterial H. pylori associated. Among type A and B, which gastritis affects antrum? Type B affect antrum. Type A spares antrum. Type of stress gastritis. 1. Cushing ulcer. 2. Curling ulcer. AIDS-induced gastritis is caused by cryptosporidia. Erosive gastritis is caused by NSAIDs and alcohol. Which mucosa is most sensitive to hypovolemia? Stomach mucosa. What's most sensitive to hypovolemia in colon? Splenic flexure. What's Mallory-Weiss tear? It's longitudinal tear in stomach mucosa after severe retching or vomiting, leading to severe hematemesis. Extent of Mallory-Weiss. GE junction to below cardia. Most common vessel implicated in Mallory-Weiss. Left gastric artery. Management and investigation for Mallory-Weiss. Endoscopy and conservative management. If no improvement, angioembolization. What's GAVE? Gastric antral vascular ectasia. Dilated venules. Site antrum. GAVE is associated with what other condition? Collagen vascular disease. Endoscopic finding of GAVE. Watermelon stomach. What's portal gastropathy? Dilated vessels in body of stomach. What's Dieulifloy lesions? Dilated submucosal arterioles which bleeds, in stomach. Seen in elderly. Snake skin appearance or strawberry stomach appearance on endoscopy is seen in portal gastropathy. What's Menetrier disease? Pathology. Acquired condition where there is hypertrophy of mucosal folds in body and fundus of stomach. Antrum spared. Pathology, overexpression of TGF-alpha. Clinical features of Menetrier disease. Hypoalbuminemia, hypo or achlorhydria, upper GI hemorrhage. Associations of Menetrier disease. CMV infection in children. H. pylori in adult. Management of Menetrier disease. Cetuximab anti-EGF, epidermal growth factor. If no response, total gastrectomy. Do Menetrier disease increase risk of cancer? Yes. Management of variceal GI hemorrhage. IV lines and blood for cross-matching. Judicious IV fluids, permissive hypotension. Airway management, prevent aspiration. IV agents, terlipressin, octreotide. Propanol avoided. Upper GI endoscopy, if varices present, banding or sclerotherapy done. What's banding? Elastic band wrapped around varices, which cuts off blood supply to them. They get strangulated and can't bleed. What's sclerotherapy of varices? Injecting a sclerosing agent into varice, using a flexible endoscope which causes fibrosis and stops bleed. Examples of sclerosing agents. STS sodium tetradecyl sulfate. Polidocanol. Ethanolamine oleate. Sodium merwate. Why deep injection of sclerosing agents are avoided? Perforation and chest pain. Steps to follow post-banding sclerotherapy. If bleeding stops and no rebelled, discharge plus propanol oral. If rebelled, second trial endoscopy. Prepare for TIPSS transjugular intrahepatic portosystemic shunt. Tubes balloon tamponade to prevent variceal hemorrhage. 1. Sengstaken-Blakemore tube. 2. Minnesota balloon. 3. Linton tube. Balloons and channels in Sengstaken-Blakemore tube. Has 3 channels: gastric balloon, esophageal balloon, stomach aspiration channel. And 2 balloons: gastric and esophageal. Disadvantages of Singstaken-Blakemore tube. Has just 1 aspiration tube, so can't aspirate from esophagus. Balloons and channels in Minnesota balloon. 2 balloons and 4 channels, 2 balloon channels and 2 aspiration channel. Balloons and channels in Linton tube. 1 balloon and 3 channels. Most common shunt used to stop esophageal varices bleed. Tips. Indications for tips. 1. Variceal bleed. 2. Intractable ascites related to portal HTN. Early complication of tips. Rupture of liver capsule. Most common complication of tips. Blockage of shunt, increases pressure, causes upper GI hemorrhage. Can cause encephalopathy because of shunting of toxins in blood from gut to systemic circulation. Types of shunts. 1. Non-selective, shunting of gut and splenic blood. 2. Selective, shunting of only splenic blood. Which type of shunts have low risk of encephalopathy? Selective shunt. Examples of non-selective shunt. 1. TIPSS. 2. Linton shunt, proximal linearenal shunt. 3. EC fistula, end to side portocaval shunt. Examples of selective shunt. 1. Inakuchi, left gastric venicaval shunt. 2. Warren shunt, distal linearenal shunt. What's Sugiura procedure? It's a esophageal devascularization procedure. Lower esophagus is devascularized. Child-Pugh score is used for to assess severity of liver disease. Criteria in Child-Pugh score. A, B, C, D, E. Albumin, bilirubin, coagulation, prothrombin time, distension, ascites, encephalopathy. Bilirubin value for grade 1, 2, 3 in Child-Pugh score. Grade 1 equals less than 2. Grade 2 equals 2 to 3. Grade 3 equals greater than 3. Albumin value for grade 1, 2, 3 in Child-Pugh score. Grade 1 equals greater than 3.5. Grade 2 equals 2.8, 3.5. Grade 3 equals less than 2.8. Prothrombin time value for grade 1, 2, 3 in Child-Pugh score. Grade 1 equals less than 4 seconds. Grade 2 equals 4 to 6. Grade 3 equals greater than 6. Child-Pugh score values for Class A, B, C liver dysfunction. Class A mild equals 5 to 6. Class B moderate equals 7 to 9. Class C severe equals 10-15. What do Forrest's endoscopic classification denote? Denotes risk of rebleeding. What's portal hypertension? Pressure in portal vein greater than 5 mm of mercury. Or hepatic venous pressure gradient greater than 5 mm of mercury. Formation of varices start at what HVPG value? Greater than 10 mm of mercury. High risk of rupture and bleeding varices start at what value of HVPG? Greater than equals 12 mm Hg. Sites for porto systemic shunts. Lower esophagus, retroperitoneum, bare area of liver, rectum, umbilicus. What's outward radiation of dilated veins at umbilicus is called? Caput medusae. Esophageal veins gets shunted blood from portal hypertension through which vein? Left gastric vein. Clinical features of portal hypertension. Presents as its complications: variceal hemorrhage, ascites, splenomegaly. Features of liver failure, jaundice. Prehepatic causes of portal hypertension: portal vein thrombosis, splenic vein thrombosis, massive splenomegaly. Post-hepatic causes of portal hypertension: Budd-Chiari, IVC obstruction, hepatic vein outflow obstruction. Cardiac causes: restrictive cardiomyopathy, constrictive pericarditis, severe TR, severe CHF. Hepatic causes of portal hypertension: grouped as presinusoidal, sinusoidal, post-sinusoidal. Presinusoidal hepatic causes of portal hypertension: sarcoidosis, schistosomiasis. Sinusoidal hepatic causes of portal hypertension: cirrhosis due to alcoholic liver disease, NAFLD, viral hepatitis, amyloidosis, HCC, cryptogenic cirrhosis. Post-sinusoidal hepatic causes of portal hypertension: hepatic sinusoidal obstruction, venuclusive syndrome. What's Banti's syndrome? Chronic condition with splenomegaly and portal hypertension without cirrhosis of the liver. Splenic vein thrombosis causes portal hypertension named as, also it's secondary to what condition? Causes left side's portal hypertension aka sinistral portal HTN. Secondary to pancreatitis. What's Budd-Chiari syndrome? It's hepatic venous outflow obstruction, at level of hepatic vein, IVC, even RA. Blockage of hepatic veins, leads to blood accumulation in liver, if gradual progressive, causes portal HTN. If fulminant, causes liver failure. Predisposing factors for Budd-Chiari. F greater than M. Pregnancy. Protein C and S deficiency. Tumors. Which lobe of liver is unaffected in Budd-Chiari? Segment 1 caudate lobe, because it has independent venous drainage, directly drained to IVC. It undergo hypertrophy in Budd-Chiari.